All right, let's go ahead and get started. Hello, everybody. Good afternoon. Welcome to the fifth of six in the Population Health webinar series. My name is Stefa Dragoon. I'm the Population Health Program Manager at the Oregon Office of Rural Health. And today our webinar is called Setting Up Your Population Health Program, featuring presentations from Emily Sullivan of Columbia Memorial Hospital, Brooke Pace of Wallowa Memorial Hospital and Medical Clinics, and Paul McGinnis of Lake Health District. This webinar series is really designed to establish a common understanding of population health and health equity strategies, and really to learn together to have conversations about how to create change in our community and within our organizations. I'm really excited that Emily, Brooke, and Paul are here today to share about programs that they designed to address specific population health needs in their communities. And so thank you so much to the three of you for being here. Next slide. So we have one more webinar in the series, and that's on August 9th. This one will not be formal presentations. It's more to talk through the learnings from the webinar series and to present questions and facilitate a dialogue with the audience. It's going to be moderated by Tracy Morton and Terry Hill of the National Rural Health Resource Center. And so I think if you are considering building out a program or you have questions about some things that you've learned through the series, this is a really good place to come and have that conversation. Next slide, please. So the speakers have no conflicts to disclose. Just before we get started, and make sure that you're muted. We'll have a Q&A at the end of the presentation where we can address any questions throughout. Since there are three presentations and they're going back to back, maybe write down a question you have for the first or second so that it's fresh in your mind for the Q&A at the end. And the presentation, all of the slides and the recording is going to be posted on the website on the webinar page, which I will put in the chat for you in just a minute. And also, if you are interested in CEUs for this session, I will also put in the form to fill out to get that credit. Next slide, please. So, and with that, I'll introduce our speakers. Emily Sullivan is a board-certified ambulatory care pharmacist. Along with pharmacy manager Jeff Chow, Emily created a clinic pharmacist program which provides medication therapy management for patients at the CMH OHSU primary care clinics in Astoria, Warrenton, and Seaside, Oregon. Brooke Pace is the Director of Communications and Experience at Wallowa Memorial Hospital and Medical Clinics in Wallowa County. Relatively new to healthcare, her commitment to the people in the community she was born and raised fuels her passion for the work she does in helping to improve their health and lives. Paul McGinnis has served rural healthcare needs for 40 years in the areas of community health development, practice facilitation, policy, and peer-reviewed research. He is currently the Population Health Advisor for Lake Health District. Thank you all so much for being here. And with that, I'm going to turn it over to Emily.
Thank you so much. It is a pleasure to speak with you today regarding our program, Creating Pharmacist Services at our CMH OHSU primary care clinics. Next slide, please. CMH OHSU has 3 rural health clinics located in Astoria, Warrenton, and Seaside, Oregon. 3 years ago, there was no pharmacist in this ambulatory clinic setting, and today we have a pharmacist embedded in a primary care clinic 5 days per week. We rotate the sites so that on Mondays and Fridays, we're in our Seaside clinic, Tuesdays and Wednesdays, we're in Warrenton, and Thursdays are in Astoria. Our long-term stretch goal is to have one pharmacist in each of those clinics 5 days per week. When in clinic, the pharmacist sees patients alongside the providers in the clinics and performs medication management for chronic diseases such as diabetes and hypertension, as well as performing complex medication reviews. The day is structured with 10 40-minute appointment slots for visits, and the rest of the pharmacist's time is dedicated either to telehealth follow-ups or indirect work such as answering drug information questions, troubleshooting medication or insurance problems, and just being available as a resource for the providers, nurses, and medical assistants in clinic. And while there are still significant barriers to overcome, we're very proud of how far we've come in this program. Next slide. So today I wanted to share how we started this program, and I'm going to talk about it in the PDSA format and then where we see it going in the future. Next slide. So first, we had to designate our operators. So before moving to the Oregon coast, I had several years of experience working as a pharmacist in primary care clinics, and I experienced the positive impact of being that pharmacist in the healthcare team and really wanted to share my experience and expertise with this new rural community. And very fortunately for me, this was in line with the goals of the pharmacy manager, Jeff Chow, and the director of pharmacy at the time, Chris Lehman, who were both passionate about clinical pharmacy services. So while I would start out providing patient care and eventually train other pharmacists to do this type of work, Jeff would provide the administration piece, so setting up meetings with other clinic administrators, reaching out to our rural health care clinic consultants, finding grant opportunities like this one through the Office of Rural Health, and working with the IT team to pull reports and mine the data that we needed from our electronic health record. We started by looking at the current state of our primary care clinics, and we already had a pretty good idea of the difficulty patients had accessing care with their primary care providers because we heard it over and over again from our patients. Most providers were booked out at least 10 to 12 weeks for a new patient wanting to establish care, and we heard that some were booked out as much as 10 months. Follow-up appointments were generally 4 to 6 weeks out at the earliest. So we knew that having a pharmacist in clinic could alleviate at least some of these access issues, allowing a patient to follow up with the pharmacist regarding a medication change in 1 or 2 weeks instead of having to wait over a month to see their PCP. We also took a look at the Medicare benchmark metrics and thought about where pharmacists could be helpful. So even if we weren't meeting our goals for, say, colonoscopies, we knew that the pharmacist probably wasn't a good fit there. So we really zeroed in on hypertension and diabetes. Of our 8 primary care providers, at that time, only half were meeting the CMS target for A1C goals, and just 3 of the 8 were meeting the CMS benchmark for blood pressure. So we knew that that is a place where we could really support our primary care providers in helping them reach those goals. Researching avenues for reimbursement has proven to be by far the most challenging piece of this, and it's still something that we are having ongoing discussions about to this day. And it's mostly because of our designation as a rural health clinic. We're subjected to different Medicare rules and different definitions of who is a provider and who is not. And unfortunately, we've gotten a lot of conflicting information from our RHC consultants and other experts in the field. So right now we have a pretty good idea of where we're headed as far as reimbursement goes, and I'll touch on that a little bit later. But up until this point, we have not been billing for our services. We've been providing this service totally free to our patients. We also had to get buy-in from the interested parties. And because the concept of a clinic pharmacist was totally new to our health system, we asked to speak at a quarterly meeting where all of the providers and the administrators of the hospital would be present. And we presented some literature on the positive impact of pharmacist interventions in health outcomes. So a PubMed search would result in endless studies. And so we picked a couple that we thought were most applicable to our site here and told them what we could do as pharmacists. And by and large, the providers were on board right away. Of course, as primary care providers, do not have endless time and resources at their disposal. They were quite happy to have an extra resource to be able to use in caring for their patients. And for the administrative side of it, we made sure to point out how this project aligned with the CMH strategic plan. And although we couldn't point to any direct reimbursement at the beginning, we made the case that pharmacist services could result in indirect cost savings, which is supported in the literature. So, for example, a pharmacist seeing medication follow-up visits in clinic frees up that provider's visit slot to see a more high acuity or sicker patient. Pharmacist interventions have been shown to reduce hospitalizations and ER visits, and also has been shown to increase generic medication utilization. So hopefully resulting in indirect cost savings in that way. I had past experience writing collaborative practice agreements, and the current agreements that are used at the OHSU clinics in the Portland metro area were provided to us. So I was able to use this kind of as a template and just adjust it to fit our needs as a rural health clinic, and just made sure everything was updated with the current recommendations from the American College of Cardiology, American Heart Association, and American Diabetes Association. And we also had to decide on a procedure for identifying which patients were appropriate for the pharmacist to work with. So who were we going to see? And we ended up taking a two-phase approach to this. For the first phase, we decided that a referral would come directly from the primary care provider on an as-needed basis. Because this was a new service, we wanted to make extra sure that the providers knew that they were still captaining the healthcare team, and we were just cautious not to, step on any toes and make sure it was very, very collaborative. Over a year into the program, we had great buy-in from the providers, and so we implemented a more population-based approach. Our IT team would pull 2 reports each week, and they would identify patients with a diagnosis of hypertension who had their blood pressure checked in the next week. And then the second report was identifying folks with a diagnosis of diabetes who had an A1C checked in the prior week. So the pharmacist would look at this report, determine which patients would be appropriate based on our inclusion/exclusion criteria, and send a message to their PCP through the electronic health record, asking if they would like the pharmacist help in the care of the patient. We were very mindful that we didn't want to put any extra work on the providers. The purpose is to alleviate some of that burden. So it was a simple yes or no from the providers, a yes triggering the referral to see the pharmacist. Next slide. Doing, of course, is the fun part, although a lot of the planning and doing did take place simultaneously, of course. When we started this program, the position of a clinic pharmacist did not exist. So I was hired on as a community pharmacist to staff our newly opened CMH Community Pharmacy, which was located inside of the Seaside Clinic. Because this was a brand new pharmacy, we didn't have an established patient population. And as such, we were only filling maybe 20 or 30 prescriptions per day, which allowed plenty of time for the pharmacist, myself, to provide patient care during pharmacy hours. So we started really small. I scheduled just one patient every morning and one patient every afternoon, and would use the pharmacy's counseling room as the exam room. And because the pharmacy was located inside of the clinic, I was still only steps away from the PCP's workstation to make for a really seamless coordination of care. As the pharmacy's prescription volume grew, this model became really challenging. And then when COVID vaccines rolled out to the public, it was nearly impossible to keep up with the pharmacy staffing and provide this direct patient care. So in August of 2021, we dedicated one full day a week to clinic. We would spend half of the day in the Seaside Clinic and then travel to Warrenton and spend the afternoons there. A year later, we received this grant from the Office of Rural Health, and that allowed us to be a catalyst to expand further. We implemented one full day in Seaside and one full day in our Warrenton clinic. A couple months later, we added the third clinic, so now we were in clinic 3 days per week. And then in January of this year, I started training and working with a second pharmacist who would also be able to provide patient care in the clinic. In April of this year, we got a grant from Care Oregon, which is really opening up a lot of doors for us as well. And in May of 2023, we dedicated 5 clinic days per week, which is our current schedule, which is fantastic. Next slide. As far as outcomes go, we did collect outcomes in a more formal way. So our pharmacist manager, Jeff, worked with the organization's informatics team to gather data like blood pressure and A1C from our electronic health record to make sure we were actually getting the outcomes that we wanted. We started sending out patient satisfaction surveys, which, while very favorable, has a very low response rate. So it hasn't been a very valuable metric up until this point. I'm hopeful that eventually that will be more valuable. We also kind of collected data or feedback informally. So we were in constant discussions with our providers and other staff. What is going well? What would you like more support with? Some of that feedback we were able to implement right away. One provider said that he wanted help in the treatment of hepatitis C management. So again, we took steps right away to make sure that we were qualified, educated ourselves, and could start seeing folks that were being treated for hepatitis C. And other asks, we really had to be careful to put boundaries around. A lot of the medical assistants wanted help doing prior authorizations, which, while very burdensome, we didn't feel was a good skill task alignment for a pharmacist to do unless there were special circumstances like an appeal or something else. So we had to be careful to make sure that the things that we were doing were really aligned with our skills as a pharmacist. Some of the outcomes that we realized were unexpected, and we noticed that people who saw the pharmacist were more likely to get their prescriptions filled at a CMH pharmacy. We were really careful to not coerce them to get their prescriptions filled with us. It's illegal to do that. And we, again, we're very mindful of that. But it seemed to really integrate seamlessly into the pharmacist workflow because I had the pharmacy's software downloaded on my laptop. While I was in the room with a patient, I could see if the drug that they needed was going to be available, if it was going to be covered by their insurance. If not, I could address it right there before we even sent the prescription. I could put the prescription into the pharmacy's workflow and mark it as a high priority so that by the time we were done with our visit, the prescription was ready to pick up. So it was just so seamless, and this contributed to another revenue stream that we could point to support our program, which was great. Next slide. Our next step is to expand our program. So right now, as far as providers, we've been working with primary care, but we're looking to see where we can be helpful in our specialty care. So whether it makes sense to have a pharmacist in endocrinology or cardiology. We're also partnering with our pharmacist colleagues on the outpatient and community side. One, they're a great resource to really identify patients who could use extra help. So who are picking up their prescriptions at inappropriate intervals or seem very confused about which medications they're supposed to be taking. And two, we really wanted to empower the community pharmacists to make appropriate changes. We implemented a therapeutic interchange protocol so that the pharmacist could make changes to prescriptions based on this set protocol, which was agreed upon by the providers. Again, really streamlining things, really saving the providers time and utilizing the pharmacist skill set appropriately. We're working with external collaborators. I mentioned a recent partnership with Care Oregon. We are working with them to make sure that their OHP members on the North Coast are taken care of appropriately. And in exchange, they are a phenomenal resource in helping us set up our billing structure. So right now we're meeting with them. They're working with our coding and billing team to figure out how we can bill for these visits and make the program really sustainable in the long run. Next slide. And we also want to expand our services. So I mentioned initially we started with blood pressure, diabetes. We also did some behavioral health. This mostly looked like follow-up phone calls for folks who were started on SSRIs or SNRIs, as medications like these have a disproportionately high discontinuation rate, and we wanted to make sure patients were accessing their medications and were able to take them. We added other services as we went along based on the needs of the clinic. So I mentioned hepatitis C. We also started doing some pharmacogenomics, which is fascinating, really, I think, the future of pharmacy. So we're working with an outside lab that does genetic testing, and then we're able to meet with the patient to go over their genetic results and talk about how their unique genetics interacts with metabolism of medications. Really neat stuff. We're also looking forward to some future services. So One of the problems that we really wanted to address was a delay in the response to refill requests. Partly, again, this is because providers are really overwhelmed with all of these responses, and partly because we've had, unfortunately, pretty high turnover in providers in the last couple years. So we've written a pharmacist and pharmacy technician driven protocol for refill authorizations, and right now, we're just waiting until we have adequate staffing to be able to implement that. And then also looking at how we can provide copay assistance to our patients using the 340B program. Of course, just like anything, there are going to be challenges. One of our goals, of course, is to make sure that this program is sustainable. I mentioned that our designation as a rural health clinic did present pretty specific challenges, and we are hoping to be able to figure out a billing structure, again, with our help from wonderful people at Care Oregon, so we can, again, make sure that this program is financially viable in the future. So there you have it. This is our 3.5 years worth of work condensed into a 15-minute presentation. I appreciate your time and attention, and I will pass it over to Brooke.
Fantastic. Thank you so much, Emily. It's fascinating to hear about your program. Today, I'm going to talk a little bit about a very specific project that we are in the initial stages of, and some equipment that we were very fortunate enough to receive an elderly services grant for that helps play a piece in this project. So the project that I'm going to talk about is an outdoor fitness trail that actually will eventually go around the campus of the hospital and our main clinic building here in beautiful Enterprise, Oregon. With the Elderly Services Grant, we were able to purchase 2 pieces of equipment specifically targeted towards our elder population that help assist in balance. So there's a skills trainer that works on some upper body dexterity, hand-eye coordination, and then another piece of equipment that's called the functional trainer that has some nice rails, a gradual slope, and a few steps that really are going to help increase the balance of the people that choose to use them. So I'm just going to talk a little bit about how we got to where we're at, and then some of the milestones along the way. So next slide, please. So when we look at population health for us here at Wallowa Memorial, there's really kind of 3 groups or things that we try and assess through this. So of course, our community health needs assessment, which is our Bible when we're looking at population health and determining the needs of our community. And not just, the community health needs assessment is something that we do every 3 years, looking at trends and things that are trending in not the way that we want them to, and what possibly we can do to help shift that. We have here what we call our Quality Council, which is a group of 5 of us that are senior directors that have lots of different hats that we wear, that we meet once a month and talk about things from population health to our current project is some document management, and we're going through all of our policies. So some of the projects are a lot more fun than others. This group is chaired by our quality director. So we always joke that we're kind of the yin and yang. Stacy, our quality director, of course, is very data driven. And then you have me, who's the communication and experience person that likes to spend a lot more time in the feelings and the fluff. So we make a pretty great duo when coming up with ideas on how to address needs. And then also just, actually listening to the community, seeing what's happening in the community, how we can help, and we'll go through a little bit of that today. So next slide. oh goodness, my slide got wonky. I created it in PDF and then converted it to PowerPoint. So I apologize about that lost S there. But for this project, the community needs assessment really highlighted some pretty glaring things as we were developing this. So the graphs that you see here are chunks pulled out of our most recent community needs assessment that happened in 2022. But data from 2019 showed us that unintentional injuries were an area of high need. So due to this data, as a way to catch more injuries due to falls, we began instituting a ground level fall modified trauma activation program. So this is a way that we can, keep track of how many people are coming into the ER, how many people are being hospitalized because of falls specifically. And then in 2022, our numbers came back and things were getting worse. So you can see our rates there that we're doing significantly worse in unintentional injury due to falls for people 65 and over, not only versus Oregon, but in the nation as well. And then when you look at our population, we live in a very, if you've never been to Wallowa County before, we live in an area with a high percentage of 65 plus. So you can see we're, almost double of what the national average is for this demographic. And so in 2022, the needs assessment data showed us again that unintentional injuries continued to be a public health issue in our community, and that the ground level fall modification program, trauma activation program, enabled our providers to catch more serious injuries, but has done very little to actually prevent the falls from happening themselves. Here in Wallowa County, we not only have a higher percentage of 65 and older, but we also only have 2 assisted living facilities. And a lot of people choose to stay home. And of course, there is a shortage of caregivers. So a lot of people are choosing to stay home that don't necessarily have the tools or resources to do that successfully. And another community aspect that came into play was in 2020, after everything was closed down with the pandemic, our one singular gym workout facility in our community closed. And so now there is no place for anyone, regardless of your age, even if you have the means to pay for a membership, to work out in a controlled setting. Of course, we're surrounded by beautiful mountains and a lot of outdoor recreation, which isn't necessarily the safest for a lot of people who are 65 plus. In 2020, we created a walking path around our campus, and we weren't really sure how that was going to be received. There's a lot of places to walk here. There's not a lot of places to walk that are free of traffic and on a flat surface. So the walking path itself is about a half a mile long. We have nice benches situated throughout the walking path. So regardless of your fitness level, you're able to access that path. And it's truly been amazing to see how many people utilize the path, not only our employees, but community members as well. And so we started to think, maybe we're onto something here. How can we take this idea of the walking path and the space that we have on campus and turn that into something that will further continue to benefit the people in our community, and then specifically looking at things that we could address in our community needs assessment. So next slide. So from this, the community needs assessment, our meetings at Quality Council, when we were putting together our strategic plan last year, we recognized that population health really needed to be at the forefront of what we were trying to do throughout the organization. Not only because it's what's right to do for your community, and that's our mission here, but also you look at number 2 on that list, and the only true way, as we know, to reduce healthcare costs is to decrease the amount of care that you're giving, especially with the amount of inflation that we're seeing here in the last year. And so, really trying to think of something that would check a number of these boxes. We talk about the continuation of care and proper emergency department utilization and hospital readmission reductions, and reducing falls will help check those boxes across the board. So we really started to dig in and think about how can we create something that will help the people in our community. So during our leadership meetings, during our quality council meetings, we have such a wonderful group of leaders that really works outside of silos. And we can go ahead and switch to the next slide. So as we're talking as leaders, start to hear a lot about EMS being overwhelmed with going to houses to assist people who have fallen that don't necessarily need to come into the emergency room. And then also our physical therapy department having people not only enrolled in services because of falls, but also an interesting thing that came about is we were having a hard time kicking people out of physical therapy. We were finding that our older population often were coming to therapy departments not because they were, actively getting better or increasing their strength or mobility, but really they liked to come and chat with everyone in the department and maybe bring a cup of coffee and sit on the recumbent bike and visit. And we were watching our backlog of patients that we were trying to get in build and build. And so we knew that we needed to create a cap for the number of visits for this group of people, but also we knew that we needed to provide an outlet for them to not only continue to get stronger to hopefully prevent falls, but also to have just those unintended benefits that we talk about of having some social interaction with other people, because a lot of our elderly population is either living alone or don't have the social network that they once had before COVID. I think that when we listened to the Age Plus presentation, we heard quite a bit about that. So from there, we decided to work with our therapists so that we could see more of these people at one time as opposed to taking up appointment slots. And with some of our community benefit earmarked dollars, we created our balance classes. And we see about 12 to 15 people at a time in the classroom here at the hospital. They work with physical therapy and occupational therapy for 2 classes a week for a total of 8 weeks. That helps them focus on, just their strengthening, coordination, help them to feel more confident and then gain strength. And of course, they go home with exercises to practice. So they're still getting those exercises, but in a social setting as well. And we started this program, the balance classes, a year and a half ago, and have seen 120 people go through these classes, which is pretty phenomenal in an area that has a population of 10,000. That's a really good number for us. And the feedback that we were getting from the class participants was phenomenal. And then we had the same problem. We had people continuing to sign up for the classes over and over again, where we were needing to get new people in. So that's when we really started to put our heads around how can we create something that gives these folks an outlet to be able to continue to keep up their strength, have some community activities, but also isn't limiting others from coming into the course. So that's our spaghetti method. It's kind of been a little bit of let's try this and see if it works. And then if it does, what's the next step? And so far, everything that we've presented is really coming along. So now we have grandiose plans of creating a fitness trail around the entire campus that will, cost a couple $100,000. And so we're choosing to look for funding, introduce these pieces of equipment in small portions. That's when I say, how do you eat an elephant? It's one bite at a time. So very excited to have received the Elderly Service Grant that allows us to start this project. Some of the challenges along the way have been, we don't have someone in our facility that's solely focused on population health. So it's always a matter of finding the time, gathering the data to even be able to recommend a project for us to start looking for funding or going to the board to ask funding for. And specifically to the equipment piece, we ordered the equipment right after we received a notification of the grant, and then it was on a manufacturer delay for 7 months. And then we got notification that it shipped. We started preparing the site. We're so excited. And then it was literally lost in transit for, gosh, it was just delivered last week. So the excitement when it came in, but it had been delivered by a third-party delivery service to a school in Wyoming. And we received full playground equipment for a school in Utah instead. And it was just a logistic nightmare tracking this down, but it's finally here and we're so excited to actually get it installed. And then going back to just program evaluation, every step along the way with the modified trauma activation, we're able to really track how many people we're seeing in the ER because of falls. And as we implement another chapter in all of the things that we're doing to hopefully help tip the balance with those falls to really see what's taking hold. Go ahead and next slide, please. So as I mentioned, we're kind of right in the middle of this project. Our next steps are to continue to look for funding to add equipment, not only just for elderly folks that are working on balance, but for everyone in the community, healthy, active adults, children. The beautiful thing about an outdoor fitness trail is all of the equipment is pretty simple. There are plaques that have instructions. We're planning on doing some YouTube videos and social media posts on how to use the equipment. There'll be QR codes for those who are tech savvy to actually watch someone utilizing the equipment on their phone and then be able to do it. We want to extend the season of use. So we get a lot of snow here in the wintertime, and the idea of this equipment just sitting for those months is kind of a waste. And so step by step, acquiring the equipment, getting the equipment installed, and then we'll start to look at options for covering to extend the season. And then, just continue to analyze the data, not only falls, but then as we start to look at, our healthy behaviors and people in the community that don't have access to outdoor recreation, how they're utilizing that and continue to promote those things. And then the fourth and final step is just to begin planning for the next initiatives. So we understand that our campus here is a place where a lot of people are familiar with and come, and we also have the space. So we're looking at some of the physical ways that we can affect the health of our community through the walking path and the fitness trail. And then next steps will be to try and implement a community garden where will hopefully deal with some of the food insecurities. And again, always going back to the benefit of creating a community and connecting our community members with each other. And I think that is it. Thank you so much for listening to me today. And I will now turn it over to Paul.
Thank you, Brooke, and thank you, Stefan, Office of Rural Health, for having me. A special call out to Michaela and Callie and Dr. Robbie Law, whose names I saw up top. It's nice to have some names of people I know. Welcome. Our project for the Population Health Grant has an acronym name, Controlling Abnormal Risks Through Engagement and Screening, which pretty much describes the actual project itself. Next slide, please, Sarah. When I was approached by the CEO of Lake Health District about serving as their population health advisor, I could think of no other place in the state in rural health where the opportunity to be successful at this would be the greatest, mainly because Lake Health District really serves as an umbrella organization. We do have our critical access hospital, Lake District Hospital. Under the district, we own and have Lake Health Clinic, which is primary care, the Lake Specialty Clinic, which supports visiting specialists from K Falls, Bend, etc. In Lake County as a whole, the county commissioners decided a few years back that they wanted to not be responsible for public health. They retain responsibility, but or accountability, but they didn't want the responsibility, and they negotiated with Lake Health District. So all of public health services in Lake County are under the Lake Health District. The other place that's different for being able to coordinate care and manage population health is that the local community mental health program responsibility of Lake County is under our organization as well. Lake District Behavioral Health is what we call it. We also run emergency medical services. And unfortunately, last month, we had to make very hard decisions about phasing out of services for home health, hospice, long-term care, and assisted living, which is kind of sad. But there's really no excuse when you look at how the pieces are together that we shouldn't be working together, because there's going to be no fights over who's getting money or anything, because it's all going into the same pot. So next slide, please. As we looked at data that we've been given over time, I keep trying to emphasize with primary care that we start figuring out a way to use the risk scores to improve health. And if you're not familiar with risk scores, they are based on large volumes of data and built-in algorithms that many insurance companies use as a proprietary software. Now, for those of you who were working in healthcare before the Affordable Care Act passed, risk scores were pretty much how an insurance company would determine that they weren't going to provide insurance for you in the next year because you were probably going to be too expensive. So it does imply costs, but costs are associated with utilization. So I keep saying, why can't we use this stuff? We have the Eastern Oregon Coordinated Care Organization for our Medicaid population, which is about a third of our people. And I must say they're one of the most transparent organizations I've ever seen when it comes to sharing back data on utilization and that kind of stuff. We know a lot about how our people are using the services and where they're going. But we get one score from them, and it's just a high, moderate, or low risk, and each plan member has their own risk score. Our electronic health record, Cerner, places a numerical value on each patient's risk, with one being the baseline, in which the score goes up or down from there. And each patient in the electronic health record has an individual risk score. So, if you're 1.9, you're at basically double the risk for cost and utilization than somebody who's a 1. The other thing that I wanted to help them use this for was empanelment of our clinicians within the primary care clinic. There's a distribution of visits that we can predict demand, but also when a clinician says, my patients are sicker, this is actually kind of a way to either verify or equalize, how tough the patient load is in terms of demand for services. Next slide, please. So Emily used PDSA, and really this project is a small study. We're going to see what happens with the outcome before we expand it. So, but when we set the program up, we used the research acronym PICO. The P is the population, the I is the intervention, C is a control group, and the O is outcomes. And I'll cover those 4 areas and kind of wrap it up. So next slide, please, Sarah. So who are our population? Well, when we looked at the data that we got from EOCCO, we saw at moderate risk 27 people on the list. We determined that we probably couldn't intervene real well with the people who are already high, but our attempt here is to try to make sure that the moderate risk people do not enter into the high risk category. The other reason we picked the EOCCO members as part of our population is because there's barriers to care, but there's no transportation barriers. There's no co-pays, no deductibles, nothing like that would prevent someone from being able to do the intervention. We had these 27 people, though. We also included that they had no primary care utilization in the last 12 months. One of the things that we learned from EOCCO is that of the members assigned to us, about 55% of them had no primary care utilization in the last year, and we need to do better at getting them to come in to provide the preventive health services that they need. When we looked at the electronic health records, these folks have a lot of chronic conditions. 48% hypertension, 22% diabetes, 33% anxiety, and 19% depression. So basically, we took those members and randomly split them into 2 groups. The intervention, most importantly, we want to reestablish contact with these people. We've been doing outreach through phone, letters, etc., and scheduling them for an appointment. We've got to connect them to their primary care people. We have one person at the clinic who just finished her training as a traditional health worker, who is the one that's scheduling and doing the outreach and phones, and she's also the clinic community care coordinating MA. But when she brings them in, she's going to use the Prepare screening tool, which is an approved social determinants of health screening tool for meeting OHA requirements. Then the traditional health worker will connect them with health resources if they need it, so she can just schedule them with behavioral health in clinic or over at the community mental health program. And then she's also got a resource directory that can help them with the social determinants of health if they have food insecurity or trouble with housing or transportation or some other needs. We have relationships with those organizations to help people out. And a lot of people are unaware of the flexible service funding that's available through all CCOs. But if there's a special needs case, we can certainly reach out to the EOCCO and see if they would pay for it. And in a sense, this is what John Kitzhaber was talking about when he was creating CCOs, telling people that, you know, maybe an air conditioner is what's going to save the most money, or pulling rotten carpet out of a house with a kid with asthma. So that's the intervention that we have. It's been going on for probably about 2 months now. And we're going to have to just work through it and see what happens in terms of how much impact we have. Next slide, please. I think I already said this. We just split those people into 2 groups, and we have the intervention on half of that group, and we leave the other ones to behave as they would on their own. But we'll also track them in terms of utilization. So our outcomes, we expect to see the intervention group not to move into high risk. We'll track movement of risk in both groups. We do, because of the conditions that these people had and them not coming in for any primary care visits over the last 12-month period, we would hope that we would better manage and control their chronic illnesses. And we'll also look at overall use of the health services in both groups and look at health expenditures for both groups. Then we'll document those connections that we've made to community-based resources for the social determinants of health. Our biggest challenge, and that's the last slide, our biggest challenge is we need 3 more docs. And, you know, it's just hard to get people who are saying yes that they want to come in, to get them scheduled and go from there. And really, I think any population health department within a health organization needs a clinician champion as part of the workload. But it's important to have their input all on the way on this. And our next steps are simply to roll it out and see what happens, and hope that we are using that risk score in a meaningful way. That's it. Thanks. I'll turn it back over to Stefa, right?
Awesome. Yes. Thank you, Paul. Huge round of applause to our speakers today. Thank you, Emily, Brooke, Paul. That was really great to hear about your programs. I wanted to open it up. We have a few minutes. We definitely have time for a few questions. I know that I have a couple in case people are still thinking, but I wanted to give folks space to ask. And Sarah, if you want, you can stop sharing too, so I can see all the people. Anyone have any questions? I can start. I'm wondering, so you have an idea for a program. I'm wondering, how do you build buy-in with your hospital and with your or clinic or community of stakeholders? Like, what does that look like?
Well, I'll just say what I said on that first slide about Lake Health District being integrated. That is a barrier for many places, but not for us. I mean, we're just all the same organization, and it makes a huge difference. I mean, the difference, you know, working through Winding Waters Clinic and the Center for Wellness, and there's just issues in wherever. But when it's 3 different organizations, and public health's different on its own. So,
Yeah.
but it is
Absolutely.
a barrier.
I was a little envious, Paul, while you were talking, because you're very right. We do have what we've established as, we call it our Wallowa County Network of Care, where once a month, all of the stakeholders try and get together. But again, it's what you can accomplish in a 1 hour meeting once a month with all of the different facets of what we're trying to accomplish. And we don't have public health in our community as well. Haven't for years. So that's certainly a challenge. The one thing that I can say about our community is everyone is very community minded here. So if you can really present the benefit and how it can help our patients, whether it's Winding Waters patients, Willow Memorial patients, Center for Wellness patients, and usually in a way that doesn't require anyone to put any additional dollars in is a good buy-in. And then we try and do events around different projects where we do ask our community partners to participate and have their name on it as well, even if it's something that we've organized and either funded ourselves or received funding for, because the intent is to care for everyone in Wallowa County. So I think just really selling the potential benefit is what's been most successful for us.
And I would just echo something that Paul mentioned during his presentation, which is how helpful it is to have a physician or provider champion for the project. When we started, we just started working with one primary care provider. He had worked with a clinical pharmacist in his residency program and was already on board with that. And because of his positive experience and his patient's positive experience, he was able to, share that with the other providers. And it was just so helpful having someone at the physician level who maybe had more clout with admin than I did at the time. So that was helpful.
Great. Thank you all. Any questions from the audience? Well, I have just one more. If you could just imagine folks who are listening have a program that they are thinking about starting. Is there something that like a piece of advice that you could leave them with as they are building a population health initiative?
The only thing I would say is that for a population health program, value-based payments and the increase of that through the Medicaid and Medicare is going to drive your initiatives a lot more easily as that shift occurs. Then it's not just about, what's our revenue stream, because we'll know what the revenues are and what we're going to have to manage health outcomes. So I welcome the value-based payments.
I think Emily had a line in her presentation as well that it can be overwhelming to how are we, one little organization, really going to affect change? And I think, don't be afraid to start small. You don't have to solve all of the problems day one. Dip your toes in and see how that goes, and then, get accustomed to the water. But I think that is a great piece of advice, because it is very easy to get overwhelmed or feel like your program isn't going to have any impact, even if it's a small impact. But remember that it can always be built upon.
Awesome. Well, thank you all again. Thank you so much. It was so good to see everybody. And that's it for this webinar. Stay tuned for the next one, which will be on August 9th, which will be more of a collaborative discussion around these topics. So I'll see you all then. Thank you. Take care.